My name is Dr. Rich Vogel. I'm a board-certified PhD neurophysiologist and a longtime member of ASET, the Neurodiagnostic Society, and I'm also current president of ASNM, the American Society of Neurophysiological Monitoring. Today's date is August 20th, 2024, and I have to say this is a very special day because I have the honor and privilege of interviewing a world-renowned otologist and neurotologist who also happens to be a prolific inventor and a pioneer in skull-based surgery, facial nerve monitoring, and patient safety. If you haven't figured it out by now, my guest today is none other than Dr. Jack M. Kartush. Dr. Kartush is a highly accomplished otologist, neurotologist, and inventor in the field of skull-based surgery. Over his distinguished career, he has held numerous prestigious positions, including being a founding partner and president of the Michigan Ear Institute, as well as a founder and president of the ASNM. A pioneer in the field of patient safety, Dr. Kartush founded the facial nerve monitoring program at the Michigan Ear Institute, and he is credited as being the first person to mark the site and side of surgery, something that has now become a standard for all surgical procedures around the world. A prolific inventor, Dr. Kartush was recognized as one of LinkedIn's top 25 medical device inventors in 2016, having developed numerous surgical tools and techniques that have revolutionized otologic and neurotologic surgery. His contributions include the Kartush stimulating dissector instruments, the NIM facial nerve integrity monitor, the Kartush laryngeal electrode, various stimulating probes, and so much more. I mean, we're really just scratching the surface here, but these innovations have significantly enhanced the safety and outcomes of ear surgeries worldwide. Dr. Kartush has also made significant contributions to medical literature, authoring over 200 peer-reviewed papers, book chapters, and clinical guidelines. His work has earned him numerous awards, including the ASNM's Richard Brown Lifetime Distinguished Achievement Award. In addition to his medical and academic accomplishments, Dr. Kartush is a respected entrepreneur, having founded American Neuromonitoring LLC, which, when it was sold to Biotronic, became one of the largest intraoperative monitoring companies in the U.S. back in 2008. His career reflects a blend of clinical excellence, innovative research, and dedicated mentorship, making him a leading figure in the field. Dr. Kartush, it's an honor to be here with you today.
Rich, the privilege is all mine, and I thank you and ASET for having me on board.
You're quite welcome. So before we get into your history and career, I understand that although you've been retired for a while, you've recently been urgently called back into active duty when the newest version of the NIM monitoring or NIM monitor had some serious issues and had to be recalled. Can you tell me a little bit about that?
Well, it's been a wild ride. So I developed stage 4 metastatic cancer to my spine, got tired of the chemo, stopped it. And so at Christmas, I was delivered to the emergency room for narcotic treatment. But my daughter, who is an otolaryngologist from Texas, flew in, and I was basically saying goodbye to my family, said it's been a great career, done. And then Allison Kartush says, Dad, wait a minute. Look, this warning has gone out all around the world last week saying the Medtronic nerve monitor, Vital 4.0, has had tons of glitches. Patients are getting injured. Users are extremely unhappy. You can't leave and let your legacy device be like this. So in the emergency room while on fentanyl, I just rolled my eyes. And I said, holy cow, I wasn't expecting this. So with this psychological warfare from my daughter, I went back on chemo, did palliative radiation for pain relief. And within a week, the president of Medtronic called and said, we need you back in the fold over here. Now, I had not been working with Medtronic for a number of years. My idea for the nerve monitor was back in 1977 when I was a medical student. studying neurosurgery in Stockholm, Sweden. I was learning neurology, needle EMG, and then working with the top neurosurgeons in the world. And I just had this idea, say, why don't we take a little EMG monitor with stimulators into the operating room? The chair of neurology thought it was a fantastic idea. The chairman of neurosurgery said, we don't need gimmicks, forget about it. So from 77, it was difficult to get things going. People really didn't believe in it. But going through Nicolay Company years later, because I worked with them on facial electroneurography for testing Bell's palsy, the device was then built, the NIM, Nerve Integrity Monitor. It was then bought out by Zomed, which was a little ENT company. And then Medtronic thought the device was so good, they might as well buy out the entire Zomed. So they bought the device and the company. And they also fortunately bought the engineer, Dave Hacker. So I've been working with the Medtronic engineer for all these decades. And every model that's come out, we've worked on together. Regrettably, since I've been retired for a number of years, they came out 2 years ago with the NIM Vital, aka 4.0, and regrettably has had a ton of problems. So rather than finishing up on home health care, I ramped things up. I got a home hospice nurse. And for the last 6 months, I've been working like crazy with the Medtronic team to find the hardware and software glitches. It's been a lot harder than I thought because there were a lot of things I probably wouldn't have introduced in this particular iteration. But so that's the Reader's Digest story of why I've been back to work and working day in and day out for the last 6 months.
That's a fascinating story, and your dedication to technology and to patient safety is just unbelievable. And the entire community is thankful for that. So I've read your CV, which is obviously impressive, and I know you went to undergrad at Michigan State Medical School at the University of Michigan. Then you did a residency in general surgery, a residency in otolaryngology, and a fellowship in otology, neurotology, and skull-based surgery.
Correct.
Not long after that, you helped to establish the Michigan Ear Institute. I know we've already skipped over a lot of your early accomplishments, but the question I want to start with is this: who were your early mentors during that time period, and what did you learn from them?
Well, my first muse was John, Paul, Ringo, and George. I was 12 years old, and the Beatles turned up on the Ed Sullivan Show, watching with my family on a little black and white TV, and the Beatles come out, and the girls are screaming so much you could barely hear the music. My dad says, "What's with these long-haired guys? They're paying the girls to scream. Nobody would scream for a bunch of long-haired guys." Well, we convinced my mom, and 2 months later, we went to a hockey stadium, Olympia, and we saw the Beatles. The girls never stopped screaming. We had the worst seats in the room behind the stage. But as everyone thought that the Beatles were big, they really didn't understand how big they were. So as a little 12-year-old, I just snuck my way right down to the stage around all the security guards, leaned right over the stage to look at Paul and John, and I just couldn't believe it. And you can see why the Beatles quit, because with all the screaming, they could barely hear themselves. But I heard them. I saw them in spitting range. I didn't know why the girls were passing out, but I said, this is the career for me. So shortly afterwards, I picked up guitar, learned how to play, started a band. I've got some other podcasts in which I go over a lot of musical details, so not to bore people here. But the short story is a rep from Decca Records, which was one of the biggest recording companies in the world out of London, offered us a recording contract, but he wanted us to wear frilly costumes. So at 17 years old, we turned down Decca Records, and they found somebody else who was willing to wear frilly costumes. And it turned out that was a guy named Davy Jones, who changed his name to David Bowie. And so David Bowie is the one that picked up that Decca contract. And then decades later, I got into another band in my surgical residency. And although it's busy doing surgical residency, I said, I got time for a band. So we put a band together. We won the Detroit Metro Times Award, got offered another recording contract. And then I demurred and said, well, maybe there's a higher chance of making it in medicine. So I left rock and roll and stayed in.
And I also saw in your CV, and I might get this wrong, but you can correct me. You wrote and recorded, I believe, the song for the Fox Evening News. Is that correct?
Yes, shortly before then, I didn't know how to play keyboards, but I heard synthesizers coming out. I bought synthesizers, put them in my apartment, taught myself how to play. And I said, well, what can I do? And so I figured out how to play the University of Michigan fight song. And within a short time, it was played in front of 100,000 people at Michigan Stadium. Someone from Fox TV heard about this, and they said, well, it's just some kid out of his apartment. So I did the opening theme to the 10 o'clock news for Fox TV. Yeah, they loved it. And then they wanted me to start doing more theme songs for the other Fox TVs. And I said, well, actually, I'm not a full-time musician. I don't think I can do this. What do you do? I said, well, I'm studying microsurgery of the ear and brain. So I had a chance again to make it, but I never gave up guitar. I continued to play in various rock bands in the Caribbean. I played all the Bob Marley bands down there. You know, finishing up my last bucket list have been fixing the nerve monitor and putting out my last songs. And so I had a song my buddy and I wrote called She's Got a Jeep that we almost got into a soundtrack for a commercial for Jeep. But Jeremy Renner wanted to do a soundtrack and they chose him over us. So we waited a couple of years and now there's a band on YouTube that's extremely popular called First to 11. They'll get 5, 10, 60 million hits per song that they cover. So they usually do all covers, and I convinced them to do my song, She's Got a Jeep. So we've just finished the video, and hopefully it'll be coming out in a month or so. So one more legacy to leave behind, a fixed nerve monitor, and maybe a soundtrack for a Jeep commercial.
Well, that's exciting. We'll all have to look for that in terms of mentors or influences at the time. The Beatles. We've talked about some of your music career. Is there someone that you can point to in the field of otology, neurotology, that was a similar level of influence for you?
Absolutely. Dr. Malcolm Graham, who did his fellowship at House Ear Institute and then came to be the professor and vice chairman of neurotology and skull-base surgery at University of Michigan. So Dr. Graham was amazing. He leveraged me to write my first publication. I go, you know, Dr. Graham, I think I'm doing a good job in otology, but I'm also playing in a band at night. So I want to put on anything else. But I did my first paper and, you know, 14 months later, see it under the covers of the Laryngoscope magazine or journal. I go, wow, this is cool. So one of the things, Rich, for me, is, you know, I've never really enjoyed drugs or alcohol very much, but certain things give me a big burst of endorphin. And just being able to get a new song, get up on stage and be able to play a hard Steely Dan solo, to get a paper out, you know, these things are self-reinforcing for me. So the more I would do it, I said, well, yeah, let's do another one. So I didn't have to have somebody over me with a whip saying, well, if you want to move from instructor to assistant professor, you know, you better get 11 publications. I just started doing it, enjoying it. And then I decided, well, yeah, you know, I could do a bunch of case reports. You know, what's the latest microtumor of the middle ear? I go, wait, how can I make a difference? You know, what's really needed? There's 10 ways of doing an eardrum repair. Why don't I take the best of the top 2? So I came up with the over-under tympanoplasty technique and on and on. And one of my biggest frustrations is I couldn't get the University of Michigan to support my belief in nerve monitoring. And just like the professor at Stockholm, Sweden, they said, you know, it's a gimmick, you know, just learn your anatomy. I said, no, the best surgeons in the world know their anatomy. And 80% of patients with big acoustic tumors, 4 centimeters, are waking up with a paralyzed face. And even small tumors, this isn't just knowing your anatomy. So I gave one of the first presentations at the American Academy of Otolaryngology around 1981 or something like that. And speaking about Nashville, Dr. Mike Glasscock was one of the first otologists in Nashville. He trained at the House Ear Institute too. So I was really nervous giving my first presentation on nerve monitoring. I finished my talk, applause, and then I see Dr. Glasscock walking to the stage. And I go, oh, Jesus, no. What's he going to say? Dr. Kartush, and my Southern accent is not very good, so I'll stop it right now. But Dr. Kartush, that was a fantastic lecture, but we don't need gimmicks. And I go, oh, man. So what do I say in front of 600 people and Dr. Glasscock? Dr. Glasscock, everybody say the same thing about the operating microscope. It's not a substitute, but I don't think you'd give it up tomorrow. And he just smiled. And then a few months later, he invited me to Nashville to help set up monitoring for he and Gary Jackson. And then, as you know, years later, they were bought out or worked out a deal with Vanderbilt. So that's how their program started. So I set up monitoring for them. One little thing that I don't usually talk about in my general podcast is the technical aspect. So Rich, for example, I asked, could I get $1,000 to make these new stimulators? No. So I had to try to make these things that, according to Dr. Graham, said looked like cattle prods. Why would I use these? So I worked at Kresge Research Institute with some of the PhDs to create the first dedicated monopolar and bipolar stimulators and the first Kartush stimulating dissectors, where you stimulate and dissect at the same time. Didn't have financing to get an EMG machine at the time. So Dave Lilly was one of the first PhD audiologists at University of Michigan. And he says, look, we just bought this auditory brainstem recording unit, Amplade, from Italy. I bet you we can change it. So instead of outputting decibel clicks, click, click, click for an auditory brainstem recording, let's get it to output electricity. Oh, that sounds great. All right, so mostly he's working on this, but the first time we want to test it, we tape on electrodes to my face for where we're going to stimulate, the stylomastoid foramen and record like an ENOG.
Mm-hmm.
And so instead of sound coming out of a sound transducer, it's got electricity coming out this cattle prod probe. So if you're setting it at 5 decibels, is that 1 milliamp, 2 milliamp, 5 milliamp? No. So Dave Lilly's on the controls. I've got these electrodes attached to my face. So Dr. Lilly sets it to 5 milliamps. Nothing, go on up. 10 milliamps, I can barely feel it. 20 milliamps, I was almost electrocuted, tearing this off. And if I was smart enough to think about it, I would realize that sound is calibrated logarithmically.
Right.
So going from 10 to 20 milliamps was what? 100-fold difference, but now in current. So after getting that lesson in math and electrophysiology, we did finally get it to work. I could not get University of Michigan to fund my first monitor. I went to the top ENT companies and go, well, look, we do tonsils and sinuses. We don't know anything about electrophysiology. So I went back to Nicolay and they said, this is a great idea, stimulating dissectors, and we already make EMG machines. So it took a few years, but the first NIM came out. Related to this is the other person that was a mentor for me was Dr. William House, who was the boss at House Ear Institute, one of the most highly regarded and for good reasons neurologic programs in the world. And Dr. House, I think everybody should read the book, Unreasonable Man. It's available for a couple bucks on Amazon. And it just shows here is one of the most innovative guys in the world. And repeatedly, everybody said cochlear implants are not going to work. In fact, the PhD head of neurophysiology at Kresge Hearing Institute at Michigan said, don't make kids undergo these procedures. There's no way you can put in a couple electrodes when there's 20, 30,000 nerve fibers there. There's no way it's going to work. Well, guess what? It just shows that you can be expert in something, but it doesn't always mean you're going to be accurate in predicting the next step, whether it's
Absolutely
electrophysiology or AI. And as you know, in AI, it grows logarithmically. So when it looks terrible 20 years ago, people say, well, at the rate we're going, we're lucky to get anything that would be even close to getting the Turing test in 100 years. Well, it's because people can't appreciate internally logarithmic functions. I did go to House Ear Institute, and I got Dr. House to use the Kartush stimulator and the nerve monitor for the first time. They didn't totally buy in. And then for the first number of years, Nicolay was not happy with me because the nerve monitor was not selling. They said, well, look, this was supposed to be a done deal. So again, I went to Zomed, and from Nicolay to Zomed, and then from Zomed to Medtronic. And I guess the last thing in this regard, before we go into more specific things for just nerve monitoring, is, as I mentioned, in 1977, I came up with an idea for the NIM when I was rotating in Stockholm. I come back as a fourth-year med student in 1978 on anesthesia, saw a resident intubate a patient. They put the endotracheal tube in. Everything seemed to be fine. But a few minutes later, heart rate and blood pressure were going crazy. And then they realized that the tube was probably not in the correct location. He probably intubated the esophagus instead of the trachea. So they called a code. Everybody ran in. They extubated, put the tube in the correct location. And fortunately, the patient was saved before they asphyxiated. One of the people that ran in for the code was Dr. Smith, the chairman of anesthesiology at University of Michigan. So I said, Dr. Smith, look, I'm just a fourth-year med student here, but it seemed to me that we're monitoring heart rate and blood pressure, but the concern was oxygen. And not until the oxygen level got so low did the heart rate and blood pressure go crazy. Wouldn't it make more sense to monitor oxygen and CO2? And just as the chairman of neurosurgery had turned to me the year before and said in Swedish, we don't need any gimmicks, the chairman of anesthesia said, we don't need any gimmicks, Jack. You just need to know, and they should have known better to be auscultating the chest. I let the idea of pulse oximetry and CO2 monitoring go. And then within a few years, the first experimental model came out, Nellcore from Japan. And indeed, the first pulse oximeters didn't always work that great, and if you had finger polish in your hand. So believe it or not, many of the anesthesia providers were actually against pulse oximetry. You go, well, how can you be against this? And not until Harvard forced every anesthesiologist in their system to use pulse oximetry did the American Academy of Anesthesiology then make it a standard. And because the risk of hypoxic injury and death is very low, you need a huge sample size to show that pulse oximetry makes a difference. So the early studies didn't look convincing because they couldn't get a good sample size to show power. And here comes the editorials. We don't need a gimmick like pulse oximetry. You can see the early studies can't show a definitive difference. Until the lawyers for Harvard and elsewhere said, you don't want to use it, fine. If you work at these hospitals, you will use it. So there was controversy, but then pulse oximetry became a standard.
One of my observations that I see today is something that I know that you experienced early in your career, and you spent a lot of your career battling against, which is this idea that the volume of injuries that happen to the nervous system are within this quote unquote expected limits. And you speak about gimmicks, and I know even today, when it comes to neuromonitoring, some surgeons will view it as a gimmick and say, well, if I'm going to operate on the thyroid, if I'm going to operate on do a middle ear surgery, there's a certain number of injuries that are going to happen, and I don't need neuromonitoring for that. And that seems to be something that sort of alongside your love of surgery has been a big inspiration, a driving force for your career. And extending from that, you're credited with founding the facial nerve monitoring program at Michigan Ear Institute.
And before that, the University of Michigan.
And before that. So what memories do you have about starting that program or those programs?
Even if you're smart, even if you're creative, if you're not persistent, you're not going to make it if you want to be on the cutting edge of medicine and surgery. Medical skepticism has been out there forever. So if you go onto my YouTube sites, you can also find videos not just on facial nerve monitoring and rock and roll, but you can see videos that I've been talking about for decades on medical error reduction and patient safety. So as you denote, I was one of the first talking about this. I wrote some of the first articles on why do surgeons make mistakes? Why do surgeons inadvertently cut the facial nerve? And this is with or without monitoring. And so the other point, Rich, you make is a very good one. So I first went to the general ENT guys and gals. I've been operating for 18 years, never had a facial palsy. Why should I use this? So the problem there was like pulse oximetry. The catastrophe rate is low, so they weren't motivated to change what they're doing. However, when I finally got the skillful and well-trained neurotologist to do it for acoustic tumor surgery, they were very skeptical. But when I said, well, Dr. Graham uses this, and now I've got Bill House and Mike Glasscock, well, all right, I'll give it a try. I come in with them and they go, wow. Not with the tiny tumors, but with the big ones. I can do a pretty good job on a 5-millimeter tumor at the porus. Now give me a 4.5 centimeter tumor where the nerve is always displaced 2 centimeters from where it should be. Now you take a Kartush stimulator, a monopolar, a PRAS, and you say, well, the nerve is usually on the superior pole, and you stimulate, beep, beep, there it is, right? I confirmed it. Now I'm going to start my dissection inferiorly where it's quiet. So these guys who were very skeptical because they were felt so trained, their sample size could be much lower because so many of their patients, especially with big tumors, had partial or total facial palsies. So again, even the people that started using it, it took a while to get over some of these biases. Mm-hmm. And, I talk a lot about human factors research. We learned a lot from aviation. We learned a lot from space. So if you're old enough to remember when the Space Shuttle Challenger went up, mm-hmm. They had their first school teacher, and they had a tremendous amount of publicity.
Christine McAuliffe.
How do you know that?
Just I was watching the television when it happened.
So 74 seconds into this, it explodes and everyone is killed. I think if you go back over it, it's murder. And there was a great study. So I started learning about errors from the aviation and the aerospace industry. Mm-hmm. And so Sarah Vaughan wrote this tremendous book about the Space Shuttle Challenger, tremendous book. And she said there is normalization of deviance. What does that mean? Well, guess what? The rocket boosters have O-rings so that when it starts to heat up, they expand and keep the gases from igniting. The engineers at Morton Thiokol who made it and all of NASA knew year after year after year that the O-rings don't expand well when it gets cold. And in numerous times when out of Cape Canaveral or Cape Kennedy, the temperature was getting low, they go, oh, well, I don't know. But every year they dodged a bullet. It told them, well, there must be so much redundancy built into this that even though they're not perfect, it's fine. However, on that day, Morton Thiokol does a video conference with NASA. and says, hey, the temperature is below 32 now. We really don't think you should fly. The director of NASA says, we've canceled, we've delayed, the president's going to be watching, the school teacher is on board. You tell me, you can prove to me that it will not work. The engineers are, well, we can't tell you, we can't prove to you, and obviously it's worked all these other times. And so the director of NASA, an MBA, not an engineer, says, unless you can do that, I want you to reverse your recommendation. Your recommendation shouldn't be to scrub the flight. Your recommendation should be, we have a concern because it's cold, but never over these last decades has it ever malfunctioned. I think it's murder.
Here we are 30 years later with astronauts stuck in space. So going back to the 1980s, so you're also credited with founding the ASNM, and going back to the 1980s when you started laying the groundwork for founding the American Society of Neurophysiological Monitoring. Why did you feel it was important to have a professional society solely dedicated to the specialty of neuromonitoring?
So to me, Rich, monitoring is just a subset of my global passion for medical error reduction and patient safety, which is why I took this detour with you here. And that's why some of my first papers, which were once again ahead of the curve, talked about, look, you're not necessarily a bad surgeon, but you've developed habits that you think are okay because they haven't kicked you in the butt yet. The O-ring seemed to be okay, and every time they used it and they didn't get burned, they said it must be fine. So I'll give you one of the biggest problems right now in something as simple as facial nerve monitoring, but there are some fundamental things that you think from the way you were taught that you're doing it right, and now you haven't had a problem for 2 years or 7 years. Every year you do it, and every year now you're teaching this. You think you're doing it right. So again, and a lot of people took my early facial nerve monitoring courses around the world. Nicolay and Medtronic, would fly me around to different countries and states, etc. And at first, how many of you monitor? Well, only a few people would show their hands. And then, how many of you monitor? Now everybody's saying it. Okay, you monitor? Show me, tell me what the impedance should be when you first boot up the machine. I don't know. If the impedance is wrong, what should the maximum impedance be for EMG when you boot up a machine? I don't know. So have you actually, as a surgeon, ever read the driver's manual? So it should be 5K. You should always do a tap test. You should do transcutaneous stimulation. So when I was resurrected like Lazarus after Christmas, I put out these last new quick facial nerve monitoring videos that I hope people will watch. To say pre-incision, these are the 3 things you should always do for patient safety and to avoid getting sued. Because I've done more monitoring expert witness than anybody in the world. And if there's any chance of saving the individuals, I will. But if I see you haven't done the right things pre-incision and post-incision, I'm going to say, I'm going to help you. Give up now and settle. 1, because you injure the patient. 2, because you're not going to win. And 3, you need to learn a lesson and understand. Oh, but I've been doing it for so many years. Well, once again, it's normalization of deviance. Because Medtronic does know that many times when there is a patient injury, they often can see that, yes, the surgeon was doing this practice that he or she thinks has been good for 17 years or 28 years, but they didn't do 1, 2, or 3, so they can't prove that the monitor was correctly set up. Or did they use insulated electrodes recording needles instead of not insulated? People got in the habit at COVID for using insulated brass needle electrodes for recording. What are you doing? When I heard about this, well, it turns out that during COVID, there was a supply chain problem. So some of the companies started selling insulated instead of non-insulated. Well, and I've got a whole video on this, so I don't want to take too much time. That needle in the muscle is your antenna. Cover it up with 40, 60, 80% insulation. Now you can't pick up small amplitude EMG responses. So there's a mistake. Now they come up with a new NIM Vital, that their artifact reduction software is better than anyone's. Okay. Is it too powerful? Have you filtered it down too much? Now you filter things down too much, and then you allow your customers to continue to use the supply chain backup of insulated needle electrodes. You can be right on the nerve, and now you're getting false negative responses. You're stimulating. You're saying, oh, the facial nerve in the facial recess where I'm drilling to put in this 5-year-old's cochlear implant, I'm not getting a response, so the nerve must be covered in bone. But what if it's not covered in bone, but you've got a false negative error for these reasons I've given you? Now you're putting the drill in there. Now you're not hearing mechanical evoked potentials. Then somewhere along the way you stimulate and you go, something's not right. Or you don't stimulate, you say, well, everything's quiet. Is everything quiet in the Western Front mean everything is perfect in nerve monitoring? We know that a quiet baseline in many aspects of monitoring is a good thing. But a quiet baseline can mean electrical silence because it's not being stimulated, or it can mean that the nerve is trashed.
I just want to ask a couple of questions about the ASNM specifically, and then we'll come back to some of the equipment later, if that's okay.
Absolutely.
So,
sorry.
If you wouldn't mind telling me just in a few words, why did you start the ASNM? And as its first president, what was your biggest accomplishment?
So there are lots of different cowboys doing amazing things throughout the world, but there was no true specialty. We were a bunch of cowboys, everybody doing things differently, discovering things. I felt the more we communicated together, the better we would learn from each other, foster education, and develop standards. Bootstrapping for a society that has never been, that was a challenge. And in the 80s, the internet is not the way it was now. So for me, just to find people around the world, oh, Dr. Tamika, you're doing spine surgery. Could we have a long distance phone call and talk about this? And so it took me, it says that ASNM started, I don't know, 1989 or 1990, but I'd been working on this for a couple of years on my own. And sometimes they list me as the first president for 2 years, sometimes 3 years. But suffice it to say, it was an enormous amount of work to get people in fields that I knew nothing about to come together. And if you look at the ASNM stationery at first, you'll see how lucky I was in finding so many top people in different specialties.
Thank you for sharing that with me too. One of my questions, as you know, that I shared with you in advance was pioneers in the field and what names come to mind. And you were kind enough to share with me a document and a bunch of files that include names of people, photos, information about them. So we'll make sure that that information becomes part of this and also gets archived. I would like to build out a portion of the ASNM's website to start dedicated to putting together historical information about the ASNM and about pioneers in the field of neuromonitoring. So thank you for sharing those as well.
The material I think that I've sent you is a gold mine, and I would be eternally grateful, Rich, if you and ASNM, maybe even in conjunction with ASET, let's bring together the leaders of ASET, ABRET. We should all be indebted to those two fantastic societies for what they've done for credentialing and education.
Completely agree. And we're definitely going to make it a priority to start to get that information on the website. One of the questions that I wanted to ask you before we move on to other things has to do with what life was like before there was facial nerve monitoring. So when we think about spine surgery, for example, we used to have the Stegner wake-up test as the primary way of evaluating nervous system function. And obviously, a lot of the work that you've done in your career, it's an extension of the phrase, necessity is the mother of invention, right? But were there any methods at all for evaluating the facial nerve in the anesthetized, so a patient under general anesthesia, when you were in training?
Rich, what a great question. So during parotid surgery, otolaryngologists in the 60s and 70s started saying, hey, these clinic facial nerve stimulators, there was no recording. You would just zap someone's face and see if the Bell's palsy was complete or not. Started coming up with a device that could do some primitive recording. So parotidectomy is very different than mastoid and intracranial surgery. You're going to be operating in this area. So rather than putting drapes here, you could put see-through saran wrap sticky drapes here, sterile. And then if you just stimulated the nerve, you didn't need EMG, you could see the twitch.
Right.
But if you've got the entire face draped off and now you're doing brain surgery or mastoid surgery or middle ear surgery, no one was putting the transparent drapes on the face. But at House Ear Institute, what they did is the scrub tech, he or she would pass the instruments to the ear surgeon, but always keep one hand on the patient's face. And if they were drilling and the patient's face twitched, they said, doctor. The good news is they detected a traumatic EMG potential by using your fingertips. The bad news is once you've stimulated the nerve like that, it's usually transected or crushed. So it did give you information to say, hey, if you didn't know you injured the nerve, you did. Take a look with your microscope and see if we need to do a repair.
Based on your experiences, what systems or processes would you like to see developed in neuromonitoring in the future, and why?
We probably need to divide that up, Rich, into training and technical. How could AI help you? I think in two ways. One would be wave recognition and changes, and that's the obvious way to look at it. To be able to do so, you're going to have to feed in petabytes of good data. Number two, my other aspect and concern about monitoring, you think you're doing it right, let's stop and take a look for a minute. And it's so hard to get people to change when they have this normalization, of deviancy. And the same thing is what happened to Boeing. Yes, they were extremely greedy. The 737 MAXs were built to save them billions and billions of dollars. They changed the software and the hardware and didn't tell the pilots. It's not just the door blowing off. This has been years now of the MBAs making decisions that are good in the short run. All the execs end up making their billion, but then all this cost cutting catches up to you. So the Alaska door blowout was only a piece of this aspect in which they let these underlying latent flaws, another key word, latent flaws, latent errors, build up. And even when the first plane crashed, they said, oh, it's not the 737, it's one of our safest jets we ever made. 5 months later, the next plane crashed. They said, well, they were both by foreign pilots. It's clearly those foreign guys that aren't well trained. Not until a year later did they say, well, we actually changed the software and hardware, and we didn't tell the pilots because we didn't want to require the airlines to pay for pilot retraining. Watch Senator Scott Hawley, whether you like Republicans or Democrats, just trashing the president and CEO of Boeing. I'm grateful for the people that are working with me at Medtronic. We created a recall, and then we got new software out 2 weeks ago. It only corrected some of the problems, and I can't talk details, but there'll be new software coming out soon. But for everyone else here who doesn't use a NEM, all these lessons are pertinent to you, your practice, how you educate and train your technologists, your surgeons, your neurologists, and your neurophysiologists. So this is not just one device. It is the underlying concept. And this is why, if I have the strength in these last couple of weeks, I want to try to do my last video on understanding how human factors errors needs to be accepted by everybody in the monitoring field.
Completely agree. We've seen a lot of radical changes, even over the past 10 years in our field, that are, I think, consequences of a lot of what you just discussed. And we're seeing it play out in real time. Is there a significant scientific breakthrough that you can point to as a major inflection point in terms of advancing the field of intraoperative monitoring?
Computer averaging, signal averaging.
Okay, that's a good one. Without that, we wouldn't have ABRs or SSEPs or VEPs, most of what we do.
Then instrumentation. I designed the Kartush stimulators, in 77. They came into production in the 80s. And when I was at monitoring meetings, I said, look, you spine guys, now that you're doing instrumentation, there's something called a Kartush stimulant dissector. You need to be stimulating through your drill holes. You need to be stimulating your screws. And again, at all these meetings until Blair Clancy came up with a paper, years after I made this and showed the first experimental, followed by the first human benefits of pedicle screw stimulation. So it was like, hallelujah. Now I go through the references, and there's no references about Kartush stimulators from years, but that's just life in the big city. But I was glad to see that this technology that had been around for years was now being applied. So sometimes it's a matter of, is it new technology? Is it just a new application that people believe in?
Yes. And do you have any thoughts about what the main areas of professional discussion or disagreement are today?
Nothing is without a battle. And I had the chance of meeting Mark Neuer, who was an amazing bulldog from the American Academy of Neurology. But from his perspective, surgeons can't do monitoring. Get rid of that NIM. We should be there. And I said, well, there aren't 10,000 neurologists doing monitoring. And so his model was he monitors in his office, and if something goes bad, he runs downstairs, and he could be present.
Mm-hmm.
But as you know, most people said, well, we can't do that. And then when I got to know Mark Neuer better, I said, well, look, I think LA is a very busy place for driving. Your residents tell me that you monitor at UCLA, I think, but you also
Correct.
monitor the VA. So how quickly do you get to the VA in LA traffic when you see signal changes?
Mm-hmm.
So our other buddy, Stan Skinner, said, look, this needs to be patient-oriented. The neurophysiologist, neurologist should be in the room. I said, I love it. I agree, Stan, but you're not going to be able to do that. Well, we do it. And so he would go in and he would cover 3 rooms, I think something like this. And he's so bright. And I said, I agree with you, but it's not practical. So now it pushes us to the remote monitoring model, which at first, just the whole concept of it, I disliked. But it became clear, and then as we merged with Biotronic, et cetera, well, there's not enough man-woman power to be able to do this. So we need to be able to leverage the numbers. Okay, so we've had these 3 models, and it was Bob Sklobasi and Augie Moeller at Pittsburgh that started the remote monitoring, but not remote monitoring from home, but remote monitoring within the UPMC system. And even that model wasn't perfect. Even that model didn't go to the level that Bob Sklobasi and I wanted, which was if you're monitoring 2 or 5 or 7 cases 300 yards away in the neurophysiology suite, what information are you getting? Well, you're seeing that these channels are okay, but you're getting a delayed latency here, or you're getting an amplitude reduction here. Is that really all the information that a neurologist or neurophysiologist should have? What about what the surgeon is doing? Well, so now you have a technologist, some of whom are superstars, and some of whom are getting started, or they're really good at pedicle screws, but they really haven't done much recurrent laryngeal, or they haven't done much EEG. So now you've got this 4-centimeter skull-based glomus jugulare tumor. And what would the information be conveyed to a remote monitorist? Good morning. How are you today? All's well. Everything set? Okay. But these are real life situations. The technologist says opening. few minutes later, getting hemostasis with cautery. A few minutes later, retracting. Well, those are key moments. And most of the time, that's pretty much what you need. But what happens now when you start seeing some changes? Does the tech have the ability to look on that screen and see, I'm at pes anserinus in the parotid? Are we at the ramus mandibularis? Are we coming out? And even if he or she understood that, and how many do, how does he or she now chat that, convey this information to the remote neurologist, neurophysiologist who isn't even seeing it? So what I've said for a long time, and now this gets back to education, here's the neurologist, great neurologist in multiple sclerosis. He or she says, I'm tired of this, been doing it for years. I heard I can make a good living doing remote monitoring. What was the mandatory training requirements for anyone doing remote monitoring in 1980? What was it in 90?
Mm-hmm.
So were you required to go in for a couple of years and see all these different procedures? You know, I do a lot of procedures as an otologist, neurotologist, neurophysiologist, etc. I'm doing stapes surgery, vesicular chain reconstruction, TIMPs, mastoids, acoustics, glomus, radical neck dissections. But if I had to learn to view that and understand the anatomy on the screen and every spine and brain surgery, that's a big ask. But is it right the remote monitoring people are blind to the surgical procedures and deaf to the surgeon's comments? Because if you're in the operating room and you hear the surgeon say, hey, I'm having a little trouble getting a response over here, turn up to 3 milliamps or do so-and-so. Hearing just a couple words of that immediately alerts anyone who is involved in this triad of surgeon, technologist, interpreter to say, I've just got one more important piece of information. This is the same thing as somebody calling up and saying, you know what, we're worried about O-rings that don't expand when it's cold. And right now, you're in a situation of cold. Now, the DABNM got started, but how many interpreters would you say in the world, what percent are DABNM certified?
Oh, less than 1%.
Now, how else can you get certified?
Oh, there's the American Board of Psychiatry and Neurology that has a subspecialty in clinical neurophysiology. There's the American Board of Clinical Neurophysiology that has a subspecialty in intraoperative monitoring. And then the audiology group.
Looking at Mark Newer's article from a number of years ago, he expects these to be board certified neurologists, having gone through the residency training, and then take subspecialty training in a fellowship, and then be able to pass, you know, some of those 1 or 2 neurology oriented exams. Well, that immediately cuts out a high percentage of people that are actually monitoring today. So now if you take the entire population of people doing neuromonitoring, you've already said probably only 1% for DABNMs. And what percent would you guess for the neurology piece of it or neurophysiology?
I mean, there's probably only 200 neurologists in the entire country who do neuromonitoring with any frequency. And I would say the ones who do it full time, most of them, not all of them, but most of them have those credentials today.
And I must say too, you know, what kind of training did they get? With so much diversity there, were they in the operating room, or were they watching from the office, where you can be watching from your kitchen and you're getting chats, giving you tiny bits, and you are blind to the surgical procedure and deaf to the surgeon's comments? I've said it before, and I'm going to say it again because it's so important. I've got a Ring doorbell on my front door. I've got two-way audio communication. I can go back and rewind. I can talk to the Amazon deliverer. And if we don't get 4 packages a day Jeff Bezos calls and said, Mrs. Kartush, is there a problem? So the technology has been there for a long time. And when I recommended this years ago, well, some people just don't want cameras in the operating room because they don't want to potentially detect a problem of malpractice and have it shown. But there's articles that have been coming out saying cameras are coming. How should you be aware of them? So this is why, to tail in, I think we need petabytes of data, electrophysiologic data, synchronized with the surgical data. And you could say, well, how could an AI video be able to parse what's happening as Kartush is dissecting the tumor away from the facial nerve down at the brainstem? Just the same way they can do all this other stuff now. So I've been predicting this for years. The technology is here now. I think ASNM and anybody else that's ethical needs to start going out and say, the time has come. We can't wait another decade. Audio, video, information to improve the interpreter.
Well said. So for the ASNM, as you know, I'm current president, and every year we have approximately 4 members that come on the board. And the same thing is true for ASET. ASET has new members that come on the board. So for new leaders that are coming on the boards of these societies, what advice would you give?
The same thing I'd give for anybody coming on a board. Don't take the job unless you plan on coming on and contributing. If you're doing it to fatten your CV, no. And you have to also have the perseverance, not just the smarts, to be able to deal with interpersonal politics. There's different ways of doing it, and some people are good at it and some people aren't. And then there's division of labor. If we're going to have some of the guys, like I think you and some of the guys in the past who were doing the stacks review, picking key articles, somehow that fell by the wayside. I thought that was a great thing. Here's all these articles, and now you've got somebody like Dr. Vogel or Dr. Mueller saying, we've sorted through all the papers for the last 2 months. These are the 2 that are key, and now we're going to parse them out for you. Fantastic. Don't drop good things like that. And then here's the other thing that you can start tomorrow for the Kartush Memorial Committee on monitoring safety and malpractice. You get a committee to say, all right, let's take a look at the 10 most common problems. Where are the weaknesses? Is it technical? Is it machine? Is the technologist? Is a surgeon? And you start dissecting that out. Number of cases, case complexity that people also need to work on. Who's the best to be able to work on inter-society things?
Well, I've been leading that effort, building bridges between the societies, because they were broken when I took my first presidency, very much so.
So I think this is extraordinarily important. But again, I couldn't get the American Academy of Otolaryngology to back me. I said, look, I want to create best practice parameters. This is 20 years ago. We don't want to do best practice parameters. Then 15 years ago, they started doing best practices. So I said, great, I'm going to renew this. So there are now best practices for cleaning out earwax, which they chose that year instead of best practices for facial nerve monitoring. I went to the executive vice president of the academy. I said, was it worth really working on that for 2 years rather than doing best practices for which operations should be monitored, which can you afford not to monitor and not waste time on, and how should it be monitored? No. And then the next year I reapplied, and then best practices in swimmer's ear came out. This is not a joke or exaggeration. So when we were arguing with Medicare, Mark Newer said, well, look, they don't have their own best practices on nerve monitoring. They don't have testing. So these things, the American Academy of Otolaryngology lost out on because they didn't listen to what I had to say, and the other societies used it to leverage them. So yes, fixing up relationships between societies, Stop being so self-centered and start thinking about the patient. You may think your model, working out of University of St. Elsewhere is the best. I can show you here's how it may fail. You may think that your private practice model is the best, but you're always monitoring states away. You never have a chance to go to the operating room. So at this point, there is no perfect model. And we have to stop dissing each other and start saying, how can we combine some of these things for what's best for the patient? How many cases is it legally appropriate, ethically appropriate, efficacious to monitor at the same time if you're doing remote monitoring? So let me ask you now, Rich, there's probably a big standard deviation. What would you say the standard is?
Well, I'd say the average is probably around 6 to 8, but the standard deviation is enormous because you do have people in rare circumstances that monitor 1 and 2, but you do have people in rare circumstances that monitor 30, 40, 50, and 60. But the overwhelming majority of people are monitoring about 6 to 8 cases at a time.
So, but up to 40 to 50.
Yes, I've seen that.
How do you humanly do that? So, and do those companies justify it? So can you monitor 40 as effectively as 4?
No, but just to be fair, I wouldn't say that those are companies. Those may be individual decisions to do that.
So here you are, you're monitoring 8 cases, and now they've added on, an acute spinal fracture. I'm just talking out of my hat over here. Well, do you want to tell the surgeon you're not going to take that case? So I'm just building the fact for saying, as moral as they want to be, and companies get pressured, just like NASA got pressured to say, we've got to get this shuttle off the field. And Boeing's going to say, we've delayed the 737 too long, we need to get it out there. Remember, just a couple years later was the space shuttle
Columbia.
Same thing. I want everybody in monitoring to understand this. Slow motion videos had shown for years that during takeoff, heat tiles would sometimes fall off and bump the wing of the shuttle. We've been seeing these little things fly off for years. So every time they dodge a bullet, they see the tiles hit the wing. Nothing ever happens. Normalization of deviancy. Yeah, I know heat tiles come off, and we can see it came off this time. I'm not going to alert the crew we're okay. Now, this time, the heat tile fell off and created a little burst, and it got people talking more and more. And just like the prior ridiculous catastrophe, people said, we've known about tiles. Never once have we had a problem with it. And this is exactly what the manager of NASA told the pilots before reentry. So just because you haven't been doing a tap test, because you haven't doing transcutaneous stimulation, just because you've said, look, if I don't get a mechanical evoked potential, I'm not going to even open a stimulator. It's expensive. The hospitals give me a hard time. So I'm not going to open up a stimulator. So I'm not going to test for current flow. I'm not going to test for train of 4. I'm going to assume that anesthesia did it. Well, did they always do it? Or did they count on you doing it? We need to learn from human factors error. You may be monitoring for a long time, but I've met men and women who thought they were doing it right for 30 years. I review the case to defend them. But if I see that they truly breached doing some of the things that would have proved that the impedance was correct, that they got proximal stimulation, because even if everything was perfect, if you don't stimulate the proximal facial nerve, you start doing a mastoidectomy, the lidocaine that you put in the ear canal to numb it up and reduce bleeding, some of it may have leaked into the middle ear. The tympanic facial nerve has bone over it, but in 40%, there are microdehiscences. So the lidocaine that you put in at the beginning of the case and very few other people have talked about this. And even if you stimulate it out here as a test in the beginning, if you don't stimulate proximal to that nerve, you haven't ruled out temporary lidocaine paralysis. And now you're in there drilling and you think you're safe. You're not getting any mechanical beeps. And so you might not even pull out a stimulator at all. I want to help everybody in the world, but if you bring your case to me and you want me to defend you, and you have never pulled out a stimulator, you haven't done the standard of care. There's more and more out there, especially my best practices, which gives a checklist of what you should be doing. If I was a plaintiff's attorney, there's no way I'd come to your deposition without reading my checklist and say, all right, did you do these 12 things? No.
That checklist is available on the ASNM website. Anybody can go there and download it now. That paper that you published in, was it laryngoscope, right?
Laryngoscope. Yeah. And I can tell you, Rich, I tried to, because remember the Academy was giving me a hard time. They didn't want to do these credentialing. So I said, all right, surely for the society that I helped start, ASNM Executive Council will say, Jack, all right, let's publish best practices through ASNM. Guess what? I couldn't get our people to agree. Well, it's coming mostly from a surgeon's perspective. No, it's not. We have leaders such as Kent Rice in technology, Rob Minahan in neurology, Gene Balzer and Chuck Yingling on neurophysiology, and Christoph Schubert on anesthesia. The ASNM doesn't know if this is going to fly. There'll be differences of opinion. This is the place that I started 3 decades before, and I couldn't get it passed through ASNM. That's why I sort of gave up for a few years, and then I went back to pushing through the Academy.
Well, the issues that you mentioned in MedMal are things that I see all the time. And, you know, going back to your analogy of the shuttle program, it's clear that we are slow to learn despite disasters. We've had 2 in the past 30 years, major shuttle disasters. I want to ask you 2 questions to wind things down, kind of rapid fire questions. The first one is, if you can pick one thing, looking back over the course of your career, of your professional life, what is that one thing that you're most proud of?
I would just say generally my early recognition and attempts on reducing medical error and improving patient safety, whether it was the NIM, whether it was marking the site, whether it was using a checklist, everything goes to the same thing.
Can you think back to the best piece of advice that you've ever received? Is there something that you can think of that would fit on a PowerPoint slide?
Yeah, I don't have some nice little saying like that. I think if you take the gist of what I've been saying, if you see that there is acceptance of harm is normal. So again, it was normal to have a paralyzed face after most large acoustic neuromas. Mm-hmm. It was not abnormal to maybe have 20 or 10% of your parotids have a paralyzed face. It was not abnormal to have a weak vocal cord after your thyroid surgery. Most of them were temporary, but it was my focus on saying, why should we accept this? And someone said, but look, the risk of facial palsy out of an acoustic, or let's just say even a cochlear implant, in experienced hands is only going to be 1 out of a few thousand, let's say. But if it's your 5-year-old,
that's right.
There was something that could have been done, it means everything in the world to you. So you need to start looking at it, not like an MBA, say, well, 50 people that get injured with the monitoring endotracheal tubes, where the reinforcing wire comes out and gives an airway problem, where it goes down into the right mainstem bronchus, where we get a false negative response. But out of the 100,000 laryngeal monitorings we're doing, that's pretty small. And so from someone that is not involved with the patient and the family, it's very easy to say, but look at our numbers. But if you don't pay attention to these small things, they're like free gimmies. When you see some little glitch here that could have been avoided, to say, how could it have been avoided? That finds foundational problems that need to be changed.
As we touched upon before, in 1984 I suggested that the surgical site always be marked preoperatively and that the team follow an intraoperative checklist before surgery could get started.
And the grief I got when I would put a little K for Kartush, but 20 years before someone can say we should mark the side and use a checklist. So it's one of the things I'm actually most proud of and most frustrated that I could not make happen, because how many people had the wrong leg amputated, had the wrong breast operated on, had the wrong eye operated on? It doesn't sound like it was very common, but Rich, you know the reason why? Mrs. Jones, I'm going to give you $1 million for your daughter's paralyzed face, but please sign here confidentiality. Is that I recommended years ago that, just like some aviation journals, once a month, go to the back and it said aviation mishaps. And I wanted to do that with surgical mishaps and monitoring mishaps. All right, you got a good team. Why did you call this as a false negative or a false positive? Why did you have to revert to a wake-up test? Why is it that your tech that seemed to be extremely well trained on auditory brainstem recording and facial nerve monitoring at the brain, but when she did their first thyroid monitoring, it was all false negative errors? Were they really trained to know that you need a different stimulus ignore period when you're stimulating farther away from the nerve than when you're stimulating at the recurrent nerve and the vocal cords? And unfortunately, my NIM was the first one that had a stimulating ignore period, and because of patents at the time, many other machines couldn't use it. So you have to have the technologist turn down the volume every time the cautery went up so you wouldn't get blasted. And if he or she turned the cautery back up, you wouldn't hear the response. That knowledge might seem great, but the field is so big that, just as I've told Mark Neuer, I think competency should be procedure-based. You could be great at endarterectomies, but do you really understand what's happening with this brainstem glioma? It doesn't automatically cross. So the last thing that we didn't quite have a chance to finish is what I tried to work out with AAN was that, all right, you want to say 2 cases safe, 6 cases safe, 20, it should be complexity based. I think if you're doing 5 pedicle screws, people are going to say, sure, add on a couple more cases. If you're doing a scoli and an urgent spinal fracture and an endarterectomy and a skull-based tumor that's 4 centimeters. So I suggested that we develop a complexity scale. We need to take into consideration not just the number of cases, but the complexity of cases. If you're doing 3 pedicle screws, add on 3 more pedicle screws. But if you're doing a tough revision scoli and a huge brainstem tumor and a lot of other things, that should limit you as to the number of concomitant cases. And what I had recommended to the AAN and the rest of the world years ago,
use a rational, objective system of determining the maximal number of cases that can be done safely by first assigning individual cases a level of complexity. Each procedure would be ranked. So the lowest complexity, for example, facial monitoring on a simple tympanoplasty, would be rated as C1. In contrast, scoliosis would be high at C5, and then there would be intermediate levels. So if you were assigned 6 cases that day, 4 pedicle screws and 2 skull-based tumors, this would be a total complexity of 16. But if you had higher complexity numbers, such as 2 scolies and endarterectomy, those 6 cases would now have a high complexity of 24. This total number should be used in helping to determine, can the remote monitoring neurologist or neurophysiologist monitor these cases effectively and safely. Regrettably, politics over the decades have prevented adoption of any safe system of determining maximum number of safe cases to remotely monitor. Until or unless a system such as this is adopted, patients will suffer.
Understood. Well, this has been a wonderful conversation. I wish we could talk for a few more hours. You're a wealth of knowledge and a founder and pioneer in the field of neuromonitoring, and it's really been an honor to spend this time with you. So thank you.
The privilege has been mine, Rich. So thank you and ASET for making this happen.